Welcome to the 2024 EMS protocol rollouts.
This is Dr. Stanley.
Hi, I'm Dr. LaPera.
And I'm Dr. Iki.
We are pleased to bring you the 6th protocol update since switching to this protocol format.
We'd also like to remind everybody to get the 2024 version by updating your app and then selecting it in the menu.
We're going to start with some updates that apply to everyone in all levels, and then focus on specific changes.
For 2024, we don't have any major updates to Big Orange Drug Box, but we did want to let everybody know that this is a moving target.
In November of this year, our drug box program will change. Look to the Western Virginia region for more updates on how we will streamline and simplify this process in the future.
First up are all the BLS updates, which comprise about half of the 2024 changes. We're also going to review all of the specific Virginia Office VMS Red Dot skills in the Western Virginia EMS protocols, and that way we maintain compliance with the current regulations. So no big changes to our airway protocol number 4 for 2024. The BIAD remains our primary airway for resuscitation. BIAD, you'll note, is an Office of EMS Red Dot skill, so if you have any questions or if you're a new provider, contact your training officer. You will note that balloon BIADs, such as the King Airway, have fallen out of favor.
And we endorse the iGel. The King is no longer exchanged as a BIAD in the hospital system.
So no changes in our number 6 breathing protocol, but you'll remember non-invasive positive pressure ventilation includes both CPAP and BiPAP.
Generally speaking, titrate up for hypoxia and titrate down for hypotension. This can be done even at the EMT level.
Again, a red dot skill though, so if you have any questions or you're a new provider, contact your training officer.
So capnography remains important in our breathing protocol. It's an important adjunct that helps us diagnose and treat respiratory complications.
We expect you to use end-tidal capnography and waveform capnography on essentially any patient with any type of respiratory problem.
But remember, this is an Office of EMS Red Dot skill, so if you have any questions or if you're a new provider, contact your training officer.
Protocol 26, Medical ROSC. This year we really want to emphasize stabilizing your patient before you transport.
In the past, we had really focused on immediate transport after return of circulation.
This is probably not in our patient's best interest.
Providers are now encouraged to focus on resuscitation before transport, so we don't sacrifice our patient's stability just to speed up the transport. Our goal is to avoid hypotension and to avoid hyperventilation. Both can cause repeat cardiac arrest and both lead to worse patient outcomes.
So if you do get ROSC on scene, take a moment or two to make sure that you've stabilized your patient before you initiate transport.
For our allergic reaction protocol, we noticed that our Benadryl dosing was a little bit conservative.
This is largely to maintain a safety cushion, especially for IV Benadryl in the elderly. But we also had written down that you could use over-the-counter instructions, which do include 50 milligrams for the oral dose. So we updated the small text to reflect that if you have an adult that you're giving Benadryl for an allergic reaction, you can give them 50 milligrams PO, whereas the standard IV dose remains 25.
For our altered level of consciousness protocol, we've added a GCS table for your reference.
So feel free to refer to this and use it in your reports.
There's been no substantial changes to the protocol itself.
For 38 diabetic, we've de-emphasized glucagon. We recognize that oral glucose or oral food and D10 are superior treatments to glucagon, and there's a significant risk of rebound hypoglycemia with glucagon. So it's still in the protocols, but it's just moved down the list a little bit.
Remember that if you have administered glucagon to a patient in the field, you need to contact medical control before you allow that patient to refuse. The other note for diabetes is to look for an insulin pump.
If you have a patient that is profoundly hypoglycemic, we would encourage you to look and see if they have an insulin pump. If you find one, we wouldn't want you to change any of the programming, but you can just unplug the tube if you find an insulin pump in a patient who is profoundly hypoglycemic.
For number 44, our stroke protocol, we've added some text about the VAN assessment.
Remember that to have a positive VAN finding, you must have arm drift.
This has always been true, but we just wanted to emphasize it here in the protocols. So when you do a stroke VAN, you first check for arm drift, and if they do not have arm drift, their VAN is negative, and you don't have to check any of the other points. For Protocol 68, crush injury, the work group really felt that albuterol was an important component. This largely tracks with the treatment of hyperkalemia, has a little bit less to do with the suspected myoglobin accumulation, but either way, it is an important aspect of treatment for crush. In 96, the work group wanted to emphasize the potential for a vector change. So the idea of dual sequential or double sequential defibrillation has fallen out of favor. It can break your monitor. But there was some utility in using the same monitor with pads just in a different place. So if you have refractory VFib or VTAC and you've shocked several times and it's not working, consider applying a new set of defib pads near your current pads and then unplug the current pads, plug in that new set you put on, and try defib again. You might want to consider changing from the anterior axillary vector to the anterior posterior vector, but the point here is that you're just moving the pads. Still, we want to recognize also when placing pads that you don't want to place it over top of any medications. Just wipe those off if it's a transdermal med, and also try to avoid any implanted devices.
102, obstetrics. We've made a few changes to this one. These changes were made to coincide with ACOG guidelines.
We've put emphasis on supporting the head during delivery to try to prevent explosive birth.
Routine suctioning has been removed from the protocol, but you may still use a bulb suction if you feel that it might be helpful.
We encourage skin-to-skin contact after delivery.
And to delay clamping of the cord approximately 60 seconds or so.
We're also endorsing leaving a larger umbilical stump. Previously, we had said 3 to 4 inches. At this time, guidelines say leave a stump of 6 to 10 inches to give a potential point of access for labs and lines at the emergency department.
This year, we also want to encourage breastfeeding for uncomplicated deliveries.
This may help both mom and the neonate, and you'll find breastfeeding in our neonate protocol. You'll also notice in the neonate protocol, we've included a table to help with looking at expected pulse ox after birth. So it's important to remember it's completely normal for a neonate's immediate pulse ox to be low and to rise slowly.
If you want to get an accurate pulse ox on a neonate, you certainly can. We recommend the right hand due to the ductal anatomy of a newborn. It is totally normal for that pulse ox to be even in the 60s for the first few minutes. It should only come up to the normal range that we're used to of, 90-ish% after about 10 minutes.
For policy 112, destination triage, there are a couple points we really want to emphasize.
In the past, what we'd recommended this for were critically unstable patients with specific conditions like STEMI, large vessel strokes, and major traumas. That's per the state triage protocol guidelines. The other thing that's new for this year, though, is that even stable patients may occasionally benefit from destination triage. So if you have a very specific patient with a very specific condition, say like a person that is having a postoperative complication, it may actually be better to go to the hospital with that surgeon that they just had surgery with than it would be to go to the strictly closest facility. We want to have that same 30-minute cap on it, so we would never recommend extending transport greater than 30 minutes for any reason, but we would consider destination triage to an alternate facility for stable patients for some of these other conditions.
Please remember, this should not extend your transport times by more than 30 minutes. If you're in a situation where that would, consider HIMS to help aid with that transport.
Along with postoperative complications, you could consider somebody with an obvious broken bone that's going to be needing orthopedics. They probably should not go to a freestanding ER, or if you have a patient in active labor that is relatively uncomplicated and stable, maybe they should go to a hospital with an OB. Patient that is, an elderly person with sepsis that's clearly going to need to be admitted, maybe they shouldn't be going to a freestanding.
Providers may also want to look at their system status, especially if transportation to an alternative site will take a unit out of service for a long period of time. Look to your agency leadership and OMDs to develop specific plans to help with this.
The last change for EMTs for 2024 comes in the 136 PEDS reference section.
It's important to note here that we are not doing high-dose intranasal Narcan for babies. There's good literature to support that a high dose of intranasal Narcan in an infant can precipitate a life-threatening withdrawal.
So for all levels, we've removed high-dose adult Narcan for children under 1 year old. AEMTs and above can still provide micro-titrated doses to babies of any age for suspected overdose. The rest of the updates are for AEMTs and above, so EMTs and EMRs feel free to skip ahead.
We want to point out a small change that we've made in the how to use section, and it regards weight-based dosing for really small adults. And we're talking about people that are under 50 kilos here or 110 pounds. For adults in this range, it is important to use weight-based dosing, and you can reference the pediatric section to find that.
There are a few very important medications to consider when we're giving doses to small adults. So make sure to use the PEDS reference and weight-based doses for very small adults under 110 pounds when using fentanyl, ketamine, Keppra, or lidocaine.
So number 4 airway, the orogastric tube remains at the AEMT level. Nothing has changed from last year, but this remains an OEMS red dot skill. Contact your training officer if you're a new provider or have any questions. Next up is Protocol 18, hyperkalemia. This is actually the first of several where bicarb had a really rough year. There's mounting evidence that bolus bicarb is likely more harmful than it is good, and then the evidence for it being good was scant anyway. So there's probably some utility in longer-term bicarb drips, but we're not do that pre-hospital. So what that means is this year we're getting rid of almost all bolus bicarb, and this is the first place you'll see it here. In 18, hyperkalemia, bolus bicarb has been removed.
As you just heard, bicarb is out in most instances, and that definitely applies to crush as well.
Rounding out the bicarb massacre is Protocol 24 medical code. So again, it's been removed from the adjunct medications. The only place that bicarb remains in the protocols is in overdose tox. We did want to use this as an opportunity, though, to point out that even though bicarb and, say, like calcium, which is also removed from the adjunct medications in code, even though they don't appear here, it doesn't mean you can't use them. Because you'll notice Narcan doesn't appear here, glucose doesn't appear here. This falls back to that system that we intend you to use with these protocols, in that you should be using more than one at any given call. So if you have a code and you think it's hypoglycemia, feel free to use glucose from the hypoglycemia protocol, or D10. So similarly, if you have a medical code, you think it's from overdose and you want to give some bicarb, you're more than welcome to do that. You'll just only find it in the overdose protocol.
At the ALS level, there's also been some changes to medical ROSC, and that revolves around maintenance drips for long transports. So in ROSC, if you have a patient who has persistent VTAC or VFib and has a transport that's going to be over 30 minutes long, you should definitely consider starting a lidocaine or amiodarone drip. Contact your medical director to develop policy around this.
For protocol number 30, dyspnea, you'll recall last year we made some changes and magnesium was removed from the AEMT scope by the Office of EMS. We replaced magnesium with epi-nebs, which are an OEMS red dot skills for AMTs. These are still in place in our protocols this year. It's especially useful for any adult in extremis, such as anaphylaxis, or for kids with reactive airway disease like croup or asthma. You can also use the T-piece valve adapter to give inline epi-nebs with non-invasive positive pressure ventilation.
For Protocol 40, OD Tox, Narcan continues to be a hot topic within the protocol work group. We've added some text here to consider using even smaller doses of Narcan.
So the idea here is you're starting off super small, as small as 0.04 milligrams, and then giving multiple back-to-back small doses, trying to titrate to respirations, but trying to avoid driving them into fluid withdrawal.
For protocol number 42, seizures, we have increased the bolus dose of Keppra to 3 grams for refractory seizures.
It's kind of interesting if you delve into Keppra dosing. There's no good evidence-based consensus dose. There are several different dosing strategies out there. Some of them are bolus, some of them are weight-based. So the work group wanted to stay in line with current guidelines, but also keep it simple. So we decided to increase it to a single bolus dose, 3 grams.
The pediatric dosing for Keppra was also updated in the pediatric reference section.
For Protocol 46 psychiatric, no major changes to the algorithm, but the work group did think it was very important to remind everyone that prior to any possible chemical or physical restraint, we should be attempting de-escalation. So de-escalation remains an important first strategy, and that restraint should only be used when the benefits outweigh the risks. This is also an OEMS red dot skill, so contact your training officer if you have any questions or you're a new provider.
In Protocol 56, major trauma, we've increased the dose of Ancef to 2 grams to provide better empiric coverage for patients with contamination. This is in keeping with current ATLS recommendations.
This is also changed in number 66 with extremity injury.
Protocol 72, burns. Unfortunately for us, the fluid rate continues to be a moving target. For 2024, the work group is endorsing the ABLS non-weight-based guidelines.
The other interesting thing to note is ABLS does include lactated ringers. So it's not something we're going to make a move in the entire protocols. We'd still say that saline is perfectly appropriate if that's what's on your truck. But if you have access to LR and you want to use it specifically for burns, that seems fine per ABLS.
For the epistaxis protocol, we're excited to include a new use of TXA. So we are using intranasal TXA for uncontrolled epistaxis. It's a newer use for TXA. It's supported by ENT physicians. To do this, we would drop 1.5 milliliters of TXA, so 150 milligrams, into a small syringe. Then use the atomizer device to deliver it directly intranasally on the affected bleeding side. You can repeat the same dose on the other side if the bleeding continues.
For 93 general procedures, we've updated some of the small text under saline lock. The big thing that is now included is a recommended order to draw your phlebotomy tubes in.
The phlebotomist would suggest that it is important to draw them in this order: blue, gold, green, and purple. Your agency may also be carrying other tubes, including red and gray.
Note that not all tubes may be in your blood draw kits, and the culture itself is a critical care procedure, but this is the recommended order from the phlebotomists.
For procedure 96, resuscitation, the work group wanted to give special consideration to tibial and humeral IOs. Some device manufacturers will specify a humeral IO as an acceptable placement. AEMTs and above should consider using this if you have agency policy and OMD authorization. For procedure number 101, cardiac procedures, the consensus opinion of the protocol work group is that the first cardioversion should be raised from 50 to 100 joules. It is felt that 100 joules is going to be better for your critically unstable patients. And it's important to note that if you are unsuccessful with your first cardioversion, that a vector change may also assist with converting the rhythm.
So that's it for the major updates to the 2024 protocols. We did want to point out again that the protocol book does include critical care. Critical care, however, is for only credentialed paramedics that are maintaining their prerequisites for each of the individual protocols. If your agency is interested in implementing a critical care program, you can certainly contact the Western Virginia EMS office for more. And for critical care paramedics that are viewing this video, we will point out that in your next in-service, there will be several updates, including reducing the number of high-fidelity simulations and removal of atropine. You'll also notice there's a brand new STEMI protocol that you receive more training in your individual rollout, which includes 15 leads and Scarboza's criteria and heparin. This is something that interests you. We encourage you to discuss it with your medical director. Also of note, all of the paramedic red dot skills will be reviewed in your in-service.
All right, that brings us to the end of the protocol rollout for this year. Just a reminder, a few final steps.
You need to complete the attestation. You can find the link below to download and print this.
Sign it and turn it into your training officer. And then you need to wait for final approval from your agency and your medical director.
We do want to extend a special thank you to everyone that's participated in the protocol work group. For the 2024 version, you'll find on the back of the book listed every person that was able to participate in the protocol work group. We'd also like to point out we're trying to maintain a yearly release schedule, so hopefully we'll see you all again in March of 2025.
See you next year.